Calcium channel blockers are primarily used in the management of cardiovascular disease. Voltage-gated calcium channel are present in myocardial cells of the conduction system, and those of the vascular smooth muscle. The various types of calcium channel, okay, so it's present in myocardial cell as well as conduction system and those of vascular smooth muscle. We know all that. The various types of calcium channel blockers have varying effects on these three areas, and it's therefore important to differentiate the use of an action. So, mechanism of action will be to decrease calcium entry to smooth and cardiac muscle, which in turn results in decreased force of contraction and a slower heart rate. So, calcium channel blocker can have that effect. Indication will be angina, hypertension, arrhythmia, Raynaud's. Arrhythmia as in narrow complex tachycardia. Okay, dihydropyridine, nifedipine and amlodipine are example. Very commonly used calcium channel blocker, nifedipine and amlodipine. Affects peripheral circulation, used for hypertension, Raynaud's, and may bring an angina due to sympathetic reflex using following vasodilatation. Side effect is headache and flushing and ankle edema. The other ones are verapamil and diltiazem. Contraindication is heart failure, heart block on beta blocker. So you can give these two when patient is already on beta blocker. Okay. Then comes the side effects of verapamil and diltiazem are headache, constipation, and heart block. Calcium channel blockers side effects are usually, as we've said before, headache, ankle edema, and flushing. The different types of the hair, they're coming back here again. Verapamil, indication angina, hypertension, arrhythmia, highly negative inotropic. So should not be given with beta blocker as make or heart block. So it decreases heart rate. Side effect is bradycardia, hypertension, constipation, heart failure. Diltiazem, angina, hypertension similar to verapamil, less negatively inotropic than verapamil, but caution should be exercised when given with taken with beta blockers. Same sort of side effect: hypotension, bradycardia, ankle, heart failure, and ankle swelling. And for the last category is the ones which are very commonly used: nifedipine, amlodipine, felodipine. Mainly used in hypertension, angina, Raynaud's, affect the peripheral vascular smooth muscle more than the myocardium, and therefore do result in worsening of heart failure, but not amlodipine. Flushing, headache, and ankle swelling can occur. Constipation for verapamil mainly. Okay. Moving to ACE inhibitor, another common medicine used in hypertension. They are now the established first-line treatment in younger patients with hypertension, and also extensively used to treat heart failure. They are known to be less effective in treating hypertensive Afro-Caribbean patients. ACE inhibitors are also used to treat diabetic nephropathy and have a role in secondary prevention of ischemic heart disease. Mechanism of action is inhibit the conversion of angiotensin 1 to angiotensin 2. Adverse effect, cough. Occurs in around, it's ACE inhibitor cough, occurs in around 15% of the patients. So this a lot of questions come regarding this, like a patient's having cough, taking ACE inhibitor. With all the details in the question, you might miss out on this information. So you have to keep these things in your head. It occurs in around 15% of the patients and may occur up to a year after starting treatment, though thought to be due to increased bradykinin. Angioedema may occur up to a year after starting treatment. Hyperkalemia and first dose hypertension, of course, may occur. It's more common in patient taking diuretics. Contraindications and cautions: pregnancy and breastfeeding, you have to avoid this drug. Renovascular disease: significant renal impairment may occur in patients who have undiagnosed bilateral renal artery stenosis. So patients who are having renal artery stenosis, they may have more problems. It's contraindicated in them. Aortic stenosis may result in hypotension, hereditary of idiopathic angioedema. Okay, monitoring: urea and electrolytes should be checked before treatment is initiated and after increasing dose. So this has to be monitored. A rise in the creatinine and potassium may be expected after starting ACE inhibitor. Creatinine and potassium can rise up to 50% increase from baseline, or up to 265 micromole per liter, whichever is smaller. So rise in creatinine and potassium may occur. to 50% increase from baseline, whichever is smaller, is acceptable, and increase in potassium up to 5.5 is acceptable. Adrenaline is a sympathomimetic amine with both alpha and beta adrenergic stimulating properties. Adrenaline induced ischemia, give phenytolamine. Is a short-acting alpha blocker, may be used as local infiltration situation like accidental injection of adrenaline. It's normally used mainly to control blood pressure during surgical resection of pheochromocytoma. So it depends. Only during surgical resection you can give, or directly during accidental injection of adrenaline. So indications, let's see, anaphylaxis can happen. So 0.5 ml, you have to remember this thing very well. 0.5 ml 1:1000 IM, that's what you give for anaphylaxis. Okay, 0.5 ml 1:1000 for IM. Cardiac arrest, of course, it has to be, just remember like this, it's like bigger, 10 ml 1:10,000, or that is or 1 ml of 1:1000 IV. So if it's 10, this is 10 as well, and for 1 this is 1 as well IV. That's for cardiac arrest. So remember, anaphylaxis 0.5 ml 1000 1:1000 IM, and 10 ml 1:10,000 IV. Okay, so another important medicine, heparin. They're all cardiac medicines which are very important. So heparin is can be given as an either unfractionated IV heparin or low molecular weight heparin, given subcutaneously. So heparins generally act by activating antithrombin 3. Unfractionated heparin forms a complex which inhibits thrombin factor 9, 10, 11, 12. Low molecular weight heparin, however, only increases the action of antithrombin 3 or 1 factor 10A. So low molecular weight heparin is more of like specific, and the others are like different. Unfractionated ones are different. Heparin overdose may be reversed by protamine sulfate. Only partially reverses the effect of lower molecular weight heparin. The table now shows the difference between standard heparin and lower molecular weight heparin. So this table is basically the difference between standard heparin and lower molecular weight heparin. So action of duration is short for standard heparin and long for lower molecular weight heparin. Mechanism activates antithrombin 3, same here as well, activates antithrombin 3, but it forms a complex that inhibits thrombin factors 9, 10, 11, 12, and forms a complex that inhibits factor 10A. So lower molecular weight heparin is only about 10, factor 10A. So both activates antithrombin 3. Okay, what are the side effects? Of course, when you have heparin, you know the side effect is bleeding. So bleeding and heparin induced thrombocytopenia can occur. It is more likely with standard heparin. Osteoporosis can also occur, and bleeding also occurs in lower molecular weight heparin, but lower cases or lower risk of heparin induced thrombocytopenia and osteoporosis. Monitoring, we can check APTT, activated partial thromboplastin time, every time to check the dosage of heparin, and anti-factor 10A, although routine monitoring is not required. So it's a bit difficult to monitor, but it's not really required. But for heparin you have to. Okay, notes, useful in situation where there is an increased risk of bleeding, as anticoagulation can be terminated rapidly. Okay, now standard in the management of venous thromboembolism treatment and prophylaxis and acute coronary syndrome. Okay, so more used in the ward setup, low molecular weight heparin. Okay, heparin induced thrombocytopenia. Okay, immune mediated, antibodies form which cause the activation of platelets. Usually does not develop until 5 to 10 days of treatment. Despite being associated with low platelets, HID is actually a prothrombotic condition. Features include includes a greater than 50% reduction in platelet thrombosis and skin allergy. So it's associated with low platelets actually, because all the platelets are used up in activation, and but it's actually a prothrombotic condition. Treatment options include alternative anticoagulants such as ergotroban, lepidolin, deniparate. Both unfractionated and lower molecular weight heparin can cause hyperkalemia. It is thought to be caused by inhibition of aldosterone secretion, so it's interesting as well. Next is aspirin. Aspirin works by blocking the action of both cyclooxygenase 1 and 2. Cyclooxygenase is responsible for prostaglandin, prostacyclin, and thromboxane synthesis. The blocking of thromboxane A2 formation. Cyclooxygenase is responsible for prostaglandin, prostacyclin, thromboxane synthesis. So aspirin works by blocking the action of cyclooxygenase 1 and 2. The blocking of thromboxane 1 A2 formation in platelets reduces the ability of thromboxane A2 formation in platelets reduces the ability of platelet to aggregate, which has led to the widespread use of low-dose aspirin in cardiovascular disease. So basically, platelet aggregation stops for aspirin. So that's why we use it in cardiovascular disease. All patients with established cardiovascular disease should take aspirin if there is no contraindication. NICE does not recommend using aspirin for primary prevention. Okay. ASA can be continued normally if patient is going for dental procedure. When to prescribe antiplatelet treatment, primary prevention. Do not routinely prescribe antiplatelet treatment for the primary prevention of CVD. Consider prescribing aspirin in people with a high risk of stroke or myocardial infarction. In deciding whether to treat or not to treat with aspirin, consider the following. Aspirin is not licensed for the primary prevention of CVD. People may be able to reduce their CVD risk through other means such as stopping smoking or starting a statin. The U.S. Preventative Services Task Force recommends initiating low-dose aspirin for the primary prevention of CVD and colorectal cancer in adults aging age 50 to 59 years with 10-year CVD risk, who are not at increased risk of bleeding, have a low expectancy or at least 10 years, and are willing to take low-dose aspirin daily for at least 10 years. Potentiates: oral hypoglycemic, warfarin, steroids. Okay. Clopidogrel, another very commonly used medicine. So clopidogrel is basically a prodrug which is activated in two steps, both by its CYP2C enzymes. The active metabolite, which then specifically and irreversibly inhibits the P2Y12 subtype of ADP receptor in the platelet, which is important in activation of platelets and eventual cross-linking by the protein fibrin. Platelet inhibition can be demonstrated 2 hours after a single dose of oral clopidogrel, but the onset of action is slow. So a loading dose of either 600 or 300 mg is administered when a rapid effect is needed. So indications is acute coronary syndrome other than STMI, along with aspirin, dual antiplatelet, loading dose of 300 mg followed by a daily dose of 75 mg for at least 3 months, 3 to 12 months. So floppy days for 3 to 12 months. Okay, following effective PCI to coronary arteries for 12 months plus aspirin. So after PCI, and high risk TIA and low risk stroke plus aspirin. Dual antiplatelet for 3 weeks, then aspirin alone, then clopid alone. Secondary prevention after stroke and TIA, aspirin is no longer used for this, following evidence from Capri trial. Okay, so next one is warfarin. It's an oral anticoagulant which inhibits the reduction of vitamin K to its active hydroxyquinone form, which in turn acts as a cofactor in the formation of clotting factor 2, 7, 9, and 10, mnemonic 972, and protein C. So P450 inhibitor increases INR. Very important. So warfarin clotting factors affected mnemonic 29710. So it inhibits the reduction of vitamin K to its active hydroxyquinone form. So warfarin iron also increased by ABX antibiotics that kill the intestinal flora or decrease vitamin K absorption. Okay, dental work: check INR 72 hours before procedure. Proceed if INR is less than 4. If unstable INR, then it should be checked again 24 hours prior to surgery procedure. So factors that may increase warfarin: liver disease, P450 enzyme inhibitors like amiodarone, ciprofloxacin. This may cause toxicity of warfarin. Cranberry juice, drugs which displace warfarin from plasma albumin like NSAIDs, inhibit plasma platelet function NSAIDs. Adverse effect of warfarin is hemorrhage, of course. If INR increases, there is increased risk of bleeding. Teratogenic skin necrosis. When warfarin is first started, biosynthesis of protein C is decreased. This results in a temporary procoagulant state. After initially starting warfarin, normally avoided by concurrent heparin administration, thrombosis may occur in venules and lead to skin necrosis. Okay, warfarin overdose, something very important. So if there is warfarin overdose, what do you do? How do you even know? So stop warfarin. Vitamin K you can give 5 mg IV. Prothrombin complex concentrate, if not available, then FFP. Okay. So in case of warfarin overdose, for major bleeding, we have to stop warfarin and give vitamin K 5 mg IV. And if not available, then prothrombin complex concentrate can be given. FFP can also be given. If INR is more than 8 and there is no bleeding or minor bleeding, then we can stop warfarin and restart when INR is less than 5. If risk factors for bleeding, then we give vitamin K 0.5 mg IV or 5 mg per oral. Risk factors include age more than 70, first year of warfarin therapy, history of GI bleeding, hypertension, alcohol excess. And dose can be repeated after 24 hours if INR is still high. So this is for if INR is more than 8 and there is no or minor bleeding. Then we stop warfarin and restart it when INR is less than 5. And if in case INR is 6 to 8 and there is no or minor bleeding, stop warfarin and restart restart warfarin when INR is less than 5. Okay, the next medications are rivaroxaban, apixaban, edoxaban. These are comparatively new medicines which are available for DVD prophylaxis and thromboembolisms. So these are the ones: dabigatran, rivaroxaban, apixaban, edoxaban. These are very commonly used nowadays. Rivaroxaban and apixaban, these are direct 10A inhibitor, and they are usually used in DVD prophylaxis in orthopedic surgery, AF, and also pulmonary embolism and DVD treatment. The reversal can be prothrombin complex concentrate or adaxanate alpha. There is edoxaban as well, which is also direct NA inhibitor used in AF and pulmonary embolism, same as rivaroxaban. Dabigatran are direct thrombin 2A inhibitor used in DVD prophylaxis in orthopedic surgery, AF. Reversal methods are given as well. So dabigatran, oral for DVD prophylaxis in orthopedic surgery. Agratroban, IV for HIT. Next is nicorandil. It's a vasodilator commonly used in angina. It has the dual property of a nitrate and an ATP-sensitive potassium channel agonist. The nitrate action of nicorandil dilates the large coronary arteries at low plasma concentration. At high plasma concentration, nicorandil reduces the coronary vascular resistance, which is associated with increased ATP-sensitive potassium channel opening. This is a nitrate-like drug. Sildenafil should not be taken while on the drug. So it's basically a vasodilator, and properties of all nitrate. Ranolazine is an anti-anginal agent that inhibits persistent or late sodium influx into myocardium in a variety of voltage-gated sodium channels. Inhibiting that current leads to reduction in the intercellular calcium channel. This in turn leads to reduced myocardial oxygen consumption. So adverse effect will be dizziness and constipation. Contraindication can be prolonged QT, combined with QT prolonging drug, severe liver failure. Okay, next is other medications which are also important, like bisphosphonates. Bisphosphonates are analogs of pyrophosphate, a molecule which decreases demineralization in bone. Um, they inhibit osteoclast by reducing recruitment and promoting apoptosis. It's particularly important to warn patients starting bisphosphonates about symptoms which will suggest an esophageal reaction, especially with alendronate. Indications: prevention and treatment of osteoporosis, hypercalcemia, Paget's disease, pain from bone metastasis. Adverse effects are esophageal reaction like esophagitis, esophageal ulcer, osteonecrosis of the jaw. MHRA has warned about an increased risk of atypical stress, fractures of the proximal femoral shaft in patient taking alendronate. The BNF suggests that take the following counseling for patient taking oral bisphosphonates. Tablets should be swallowed whole with plenty of water while sitting or standing, to be given on an empty stomach at least 30 minutes before breakfast, or other oral medication. Patients should stand or sit upright for at least 30 minutes after taking tablet. Anti-gout medications. Acute gout. You give colchicine, NSAIDs like indomethacin, naproxen, phenylbutazone, ibuprofen. Chronic gout, you can give probenecid, sulpinfazone, allopurinol, xanthine oxidase inhibitor. Okay, for allopurinol is the main one here. Used in the prevention of gout, it works by inhibiting xanthine oxidase. So allopurinol is used in the prevention of gout. It works by inhibiting xanthine oxidase, which is responsible for the oxidation of 6-mercaptopurine to 6-thiourea acid. Initiating allopurinol prophylaxis. See negation below. Allopurinol should not be started until 2 weeks after an acute attack has settled. So during the acute attack, we usually just ignore it. Start with colchicine. Initial dose of 100 mg once daily with the dose started every 3 weeks to aim for serum acid, uric acid less than 300 micromole per liter. NSAID or colchicine should be used when starting allopurinol. So the indications are recurrent attacks. The British Society for Rheumatology recommend in uncomplicated gout, uric acid lowering drug therapy should be started if a second attack for further attacks occur within 1 year. Tophi, renal disease, uric acid renal stones, or prophylaxis if on cytotoxics or diuretics. Leishman syndrome often taken allopurinol for life. So Leishman syndrome is something to look out for. Indications will have recurrent attacks, tophi, renal disease, uric acid, renal stones, prophylaxis if on cytotoxics. Azathioprine, metabolized to active compound 6-mercaptopurine. Xanthine oxidase is responsible for the oxidation of 6-mercaptopurine to 6-thiourea acid. Allopurinol can therefore lead to high levels of 6-mercaptopurine. Much decreased dose must therefore be used if the combination cannot be avoided. Cyclophosphamide. So with this, there's a problem. Allopurinol decreases renal clearance, therefore may cause marotoxicity. So let's do this part again. Metabolized to active compound 6-mercaptopurine. That's for azathioprine. Xanthine oxidase is responsible for the oxidation of 6-mercaptopurine to 6-thiourea acid. Allopurinol can therefore lead to high levels of, so this inhibitor will stop it and leads to high level of 6-mercaptopurine. There will be build up of that. Okay, next would be hormone replacement therapy. Hormone replacement therapy involves the use of a small dose of estrogen combined with progestogen in women with a uterus to help alleviate the menopausal symptoms, postmenopausal symptoms. And the indications for HRT have changed significantly over the past 10 years as the long-term risks have become apparent, primarily as a result of Women's Health Initiative. Indications: vasomotor synthesis, flushing, insomnia, and headaches. Premature menopause should be continued until the age of 50 years. Osteoporosis, but should only be used as second line treatment. The main indication is the control of vasomotor symptoms, it's flushing, insomnia, and headaches. The other indications such as reversal of vaginal atrophy and prevention of osteoporosis should be treated with other agents as first line therapies. Other benefits includes decrease in incidence of colorectal cancer. Potential complications would be increased risk of breast cancer by addition of progesterone. So progestogen. So we have to remember that progesterone that is can increase risk of breast cancer. And increases of venous thromboembolism by the addition of progestogen. So this is kind of a risky drug, I think. Then decreased risk of endometrial cancer, that's good, and decreased by the addition of progestogen but not eliminated completely. The PNF states that additional risk is eliminated if a progesterone is continuously given. So adverse effect: nausea, breast tenderness, fluid retention, and weight gain. Okay, in breast cancer, WHO study, there was a relative risk of 1.26 at 5 years of development breast cancer. The increased risk related to duration of use. Breast cancer incidence higher in women using combined preparation compared to estrogen only preparation. So for breast cancer, since progesterone that is increases risk of breast cancer, it's better to give only estrogen preparations for these women. The risk of breast cancer begins to decline when HRT is stopped, and by 5 years it reaches the same level as in women who have never taken HRT. Combined oral contraceptive pill. The decision of whether to start a woman on the combined oral contraceptive pill is now guided by the UK MEC. This scale categorizes the patients, the potential cautions and contraindications according to a 4-point scale as detailed below. 1. A condition for which there is no restriction for the use of the contraceptive method. 2. Advantages generally outweigh the disadvantages. 3. Disadvantages generally outweigh advantage. 4. Represents an unacceptable health risk. So combined OCP can increase the risk of breast cancer as there is progesterone in it, increased risk of DVT, and decreased risk of endometrial carcinoma. So it's all due to the progesterone part. Examples of UK MEC 3 conditions include more than 35-year-old and smoking less than 15 cigarettes per day, BMI is high, migraine without aura, and more than 35-year-old, having history of thromboembolic disease in first degree relatives, controlled hypertension, breastfeeding 6 weeks, 6 months postpartum. And this one is similar to that with some additional factors like breast cancer, major surgery with prolonged mobilization, uncontrolled hypertension, history of stroke or ischemic heart disease, history of thromboembolic disease or thrombogenic mutation, migraine with aura, BMI more than 40, more than 35-year-old, and smoking more than 15 cigarettes per day. Diabetes mellitus diagnosed more than 20 years ago is classified as UK MEC 3 or 4 depending on severity. Okay, another hormone therapy is tamoxifen. It's a selective estrogen receptor modulator which acts as an estrogen receptor antagonist and partial agonist as well. But it's used in the management of estrogen receptor positive breast cancer. Okay, so adverse effect would be hot flushes, menstrual disturbance, vaginal bleeding, amenorrhea, venous thromboembolism, endometrial carcinoma, alopecia, cataracts. Raloxifene is a pure estrogen receptor antagonist and carries a lower risk of endometrial cancer. So all these are having all these, like the progesterone ones causes decreased risk of endometrial carcinoma, and these ones increases. Okay, now let's move to the other medicines which are antivirals, very important as well. Acyclovir, very important, commonly used in viral meningitis, is phosphorylated by thymidine kinase, which in turn inhibits the viral DNA polymerase. You have to remember the DNA polymerase part because it inhibits it. Ribavirin effective against a range of DNA and RNA virus, interferes with the capping of viral mRNA. Interferons inhibit synthesis of mRNA, translation of viral protein, viral assembly and release. Okay. Amantadine used to treat influenza, inhibits uncoating of virus in cell. Now, antiretroviral agent used in HIV like nucleoside analog reverse transcriptase inhibitor NRTI. Examples: zidovudin, titanosine, lamivudin. Protease inhibitor. You have to remember what it does. Protease inhibitor Inhibits a protease needed to make virus able to survive outside the cell, like indinavir, nalfenavir, ritonavir, saquinavir. And NRTI, non-nucleoside reverse transcriptase inhibitor, like nevirapine, efavirenz. Okay. So HIV antiretroviral, P450 interaction, and nevirapine, that is NNRTI, is like induces P450, and protease inhibitor inhibits P450. So P450 is like, inhibition of P450 is basically building up, causing toxicity, I think. Nucleoside analog reverse encryptase inhibitor, NRTI, that is zerovorin, has already talked about it. Examples: general side effects would be peripheral neuropathy, zerovorin, anemia, myopathy, black nails, zidanosan, pancreatitis. Okay, non-nucleoside reverse transcriptase inhibitor. Examples, if given already, side effect P450 interaction induces, and this rash. Protease inhibitor, examples indinavir, ritonavir. Side effects are diabetes, hyperlipidemia, buffalo hump, central obesity. And indinavir, renal stones, ritonavir, inhibitor of the P450 system. Okay, next is cyclosporin, another very important medicine to think about. So it's an immunosuppressant basically, which decreases the clonal proliferation of T cell by reducing IL-2 release. So it's immunosuppressant which decreases clonal proliferation of T cell by reducing the IL-2 release. So yeah, it acts by binding to cyclophilin, forming a complex which inhibits calcineurin, a phosphatase that activates various transcription of factors in T cells. So T cell proliferation is released. So it's an immunosuppressant since IL-2 is released as decreased as well. So indications would be Crohn's disease, rheumatoid arthritis, psoriasis. Has a direct effect on keratinocytes as well as modulating T cell function following organ transplantation and pure red cell aplasia. The adverse effect would be nephrotoxicity. So cyclosporin is a nephrotoxic drug, hepatotoxic drug. There will be fluid retention, tremor, hypertension can occur, hyperkalemia can occur, hypertrichosis can occur, hyperplasia of gum, impaired glucose tolerance can occur. Cyclosporin and tacrolimus, mode of action inhibits calcineurin, thus decrease IL-2. Tacrolimus is a macrolide antibiotic used as an immunosuppressant to prevent transplant rejection, very commonly used. It has a very similar action to cyclosporin. The action of tacrolimus differs in that it binds to a protein called FKBP rather than cyclophilin. Tacrolimus is more potent than cyclosporin and hence decrease the incidence of organ rejection. However, nephrotoxicity and impaired glucose tolerance is more. So this is the worst part. There is more nephrotoxicity in tacrolimus.